All right. Thank you so much for everyone for being here this evening. If you don't know me, my name is Christina Sire. I'm the executive director for the Iowa chapter of the American Academy of Pediatrics, and we are here to have an evening about advocacy-focused conversations, explicitly focusing on the Medicaid landscape and all the intersections that wrap around the health and well-being of the children and families of Iowa. Um, just as a background piece, I'm sure everyone in this room already knows, but Medicaid and CHIP cover nearly half of all children in the United States, which means any policy shift, including any piece that interacts with public well-being, hits the pediatric world first and hardest. So today we're bringing together experts who live at the intersection of healthcare delivery, public health, and policy. So together we want to explore what's changing, what's at risk, probably everything, and also how we can move forward together as a unified voice and hopefully make some positive, impactful change. But first, I'm going to introduce our wonderful panelists who are going to bring so much more expertise than I could ever dream to bring to the table. So starting with Ann Discher worked at Child and Family Policy Center for 10 years before the merger with the Iowa Policy Project, serving as a research associate, communication director, and most recently as executive director. Her prior experience includes neighborhood organizing, local government reporting for a community newspaper, and research on social and tax-based disparities in U.S. metropolitan areas. She has a bachelor's degree from Luther College in Decorah and a master's degree in urban and regional planning from the University of Minnesota. So thank you, Anne, for being here. Next, we have Luke Elzinga. Luke is from DMARC as the communications manager in April of 2014 and has been the biggest instrumental piece to ensure that their advocacy program continues as strong as it has been. Currently serving as the policy and advocacy manager, he directs DMARC's advocacy efforts around the Supplemental Nutrition Assistance Program, or SNAP, and other nutrition and anti-poverty programs at the local, state, and national level. Luke earned his BA from Iowa State University and his Master of Public Policy from the University of Northern Iowa. So thank you, Luke, for being here. And then last but certainly not least, I've worked with Nelle in a myriad of spaces. So I'm very excited that she, along with all of our other experts, are here. But Nelle has been the Advocacy Network Director for Iowa ACES 360 since the fall of 2021 and has been an advocate for policies and system changes to improve the health and well-being of Iowa's children and families. She coordinates the Iowa ACES Policy Coalition, is part voting member of the State Medicaid Advisory Council, or MAC, and is always at the state capitol building, creating relationships and building relationships to advocate with state leaders and leads policy research efforts to advance new ways of responding to ACEs. She has her bachelor's in health policy and management from Providence College and has a master's of public health from University of Iowa. That was a whole lot of verbiage for me. I will be the moderator this evening, so you're going to hear from me quite a bit, but I'm going to go ahead and get us into the questions. So my first question about Medicaid is going to be directed at Anne and Nelle, whichever one wants to go first. But what recent Medicaid changes are having the greatest impact on pediatric access to care, especially for children with complex medical needs or disabilities?
Flip before it, Mary Nell. Why don't you give it a why don't you start?
Great. Thanks, Anne. Thanks, Christina, and appreciate the opportunity to chat with you all. I think every time I talk to pediatricians, I'm just reminded you are some of the most passionate advocates and some of the most trusted messengers that we have in these days and times. So really appreciate the opportunity to get to speak with you all. So I think when we're talking about Medicaid, I would say one of the clearest lessons from the unwinding of continuous coverage is how disruptive and harmful that disruptions to care and coverage can be for these kiddos, especially kids with special health care needs. As a reminder, during the pandemic, families were protected from disenrollment from Medicaid, but once that safeguard was lifted, almost 90,000 Iowa kids lost coverage, 3 times as much as was projected, and most were dropped due to procedural issues, missing paperwork, things like that, not because they were ineligible. So why am I talking about that? That was in the past. Christina's asking about what's going on right now that is putting kids at risk. But we know looking ahead, administrative burdens like paperwork, like renewals and redetermination, those are going to only increase for kids. Iowa is shifting in response to HR1 eligibility checks from 12 months to every 6 months, doubling the frequency that families are going to have to navigate all of that red tape. And when we're talking about kids and Medicaid, it actually gets even more confusing because kids often remain eligible when their parents don't. So, for example, again, in response to HR1, a refugee child might still qualify for Medicaid even when their parent loses coverage. And so, if we don't have clear and repeated communication, families might mistakenly assume that their kid no longer qualifies because they got a notice that they no longer have coverage. So when we're talking about kids with complex medical needs, you know better than anyone, even a short lapse in coverage that can be missed therapies, delayed specialist visits, increased stress for caregivers. And so that's why continuous coverage, especially for kids, has been such an important lifeline. And that is now at risk because of HR1.
Nice to see everyone here. I'll maybe just piggyback on that a little bit. I mean, to be clear, there's very little verbiage in HR1 that goes out of its way to reduce coverage for kids. Like, there's nothing, like there are some very specific pieces of the legislation that are targeted in reducing enrollment among adults. But life is complicated. And for reasons that Mary Nell said, there are many indirect threats to kids' coverage in this bill. It is a lot of the paperwork challenges that she talked about, the ramping up of enrollment. It's sort of when we expanded Medicaid back in 2013 to cite other fun healthcare policy battles in the past, people talked a lot about what they call the welcome mat effect, which is when parents find out that there's access to coverage for them, then they turn out it's like, oh, my kids qualify too, even though they had always been covered. Parents didn't know. And so the concern is the exact opposite. They will hear that they're losing coverage and they will assume their kids are not covered. I think the other pieces of the bill, and I think Luke will talk about SNAP. And there are some pieces of HR1 that are going into effect really quickly around SNAP. Plus, we have a government shutdown. So there's some stuff happening around SNAP really quickly. The Medicaid provisions of the bill actually play out a little more slowly. But in addition to that sort of paperwork piece that I think puts kids' coverage at risk, there are other parts of the bill that really will make it, that essentially shift responsibility for Medicaid, a larger share of it to the state. And so it's going to put incredible fiscal strain on the state of Iowa at a point and at a time in which we're already have opened up kind of a structural deficit in our state budget. And so when you start thinking about the kinds of decisions that will get made in the context of financing changes, again, kids are protected. There's provisions within Medicaid. Anyone who likes to use bad acronyms, EPSDT, which provides a really robust set of protections for kids coverage. There's certain kinds of coverage for kids that cannot be cut, that they can cut for adults. Nonetheless, when the budgets get tight, there's only so many ways to cut costs, and it is going to be really impossible to hold kids harmless in that context, even if they're not directly targeted in the bill.
Thank you for that. And Marino really set me up nicely for the next question. As Anne stated, we're going to talk about SNAP in depth because, of course, there's an intersection very clearly there. So how does HR1 overhaul SNAP, including reduced benefits, the new work requirements, and cost shifting to the state, and how that intersects with health access issues for kids? And I'm going to look to Luke as our expert for SNAP first.
Yeah, and thank you so much for having me, and so happy to talk with you all about this. Um, there's a lot of changes to SNAP in the bill, and so I'll try to keep it as top level as possible. There were some cuts to future benefits, so no one's benefits actively were reduced, but there are cuts to future benefits. Some of the changes that are coming November 1st are around eligibility. One of those is expanded work requirements. So that's for older adults 55 to 64, parents and caretakers of children 13 and up. And then they removed some exemptions for veterans, unhoused people, and young adults aging out of foster care. So all those folks I just mentioned are going to have meet a 20-hour a week work requirement. And even for folks who are working 20 hours a week or should be exempt, like Anne said, that's not unfortunately how it always works out. So some people who should be exempt may have trouble, verifying that exemption with the state. The other piece, is a ban, for refugees, asylees, and humanitarian immigrants from SNAP. That is going into place November 1st. USDA FNS still has not issued guidance to states, and we are 3 days away from that change. We don't have the exact number of refugees and asylees who will lose SNAP benefits in the state. It's a few thousand, and about half of them are children or seniors. So, we are going to see that impact in November on those households. And if a parent or caretaker of a teenager is not meeting that work requirement, they will lose benefits. The child would not, but still, we would see household benefits reduced. And we know that that's going to impact children too. So, those are the more immediate ones. And then there were some really big structural changes too of how states administer SNAP. So right now it's states pay 50% of the administrative costs and benefits are fully federally funded. States are going to have to pay an additional 25% of those administrative costs. And for the state of Iowa, that looks like $15 million that the state is going to need to make up in their HHS budget next year. And like Anne was talking about, that's really concerning given the current state of our, we do have, I will say we're in a better situation than some states, but our outlook is not great right now. And so there's a concern there too of if the state could be on the hook for benefits, which is tied to the payment error rate. And I could go on for hours about that, and I won't. Um, but if our payment error rate went above 6%, we could be on the hook for an additional $25 million every year. And so not only would this put pressure on the state to potentially look for ways to reduce SNAP eligibility, which they could do. Our SNAP income eligibility is 160% in the state right now, and they would have the ability to move that to the federal floor of 130%. That would kick about 25,000 Iowans off SNAP, and a good chunk of those are kids. We hope it doesn't come to that. But I think there's a real fear there, and it will just put pressure on HHS's budget and other programs that may not even be directly related to SNAP. So I think this next state legislative session is going to be a very pivotal year for SNAP, for Iowa HHS. And our hope is we can keep this payment error rate under 6%. We can find the additional admin funds without cutting access. But it's going to be a tough session, I think.
Yeah, do either of our other panelists have a response or anything you'd like to add to that question? Yeah, no, nothing to add to that. We don't want to touch that too much.
I do. I'm
Okay.
thinking about this as I go. The government is shut down, and very likely SNAP benefits are not going to go out to anyone on November 1st. And so I think we're going to get a taste right now of what it would look like. Because here's the thing, if at any point the state doesn't put up the extra money for admin or doesn't, I mean, there's some cuts they can make, like they can change the eligibility level. But like if they're faced with an extra 15 million for administration and an extra 25 million for benefits, the concern is they would drop SNAP altogether. And so I think we're at a moment we're going to see what that looks like. And I think I hope that people look at that and say, we can't do this. This is too important. It's a weird concern that if food pantries step up, if things happen, that some people might look at that and say, we don't need SNAP, see? And that would not at all be the conclusion that I would draw, because I think over the long run it's just going to be really terrible for families. But I do think we're getting an unfortunate real-time test of what our world looks like without SNAP, and I don't think we're going to like it very much. So sorry, I did
Oh,
have something else.
no, thank you, Anne, for adding that. And if food pantries are able to meet the demand, I would be flabbergasted. I'm very concerned about next week. There's there is not a replacement for $45 million in SNAP benefits that should be going out at the start of the month. And I also have a fear, I could talk for a while about the shutdown and I won't, but I also have a fear with these changes November 1st. If there's households who are not getting benefits, who are being told no one's getting benefits right now, but then find out 3 weeks later that actually they were removed from the program and are never getting those benefits or need to reapply, um, I think that is a real concern. And the timing of this could not be worse. I mean, November is always the busiest time at food pantries, as it is. We're already seeing record-breaking need at food pantries, as it is. We've seen a $500 million in food for food pantries cut on top of the largest cut to SNAP in history. Um, there's not many things working in our favor right now. And so I think next week is going to be absolutely devastating. And I think a lot of people are going to realize how critical SNAP is to Iowa, and not just the people who rely on it, but our wider.
Thank you. Yes, as I said, the intersections of all these different programs that help keep a family going day to day is something that we want to dive deeper into how we can effectively communicate that to the decision makers higher up. But I'm going to take us back to the Medicaid piece of this. So looking at Medicaid, and I want to try and have a taste of when the rollout or rollback, I forget the correct terminology, occurred previously. How is coverage interruptions during the redetermination going to uniquely affect children's development, especially preventative care and continuity of care with providers? And I'm going to look to either Mary Nell or Anne, whichever wants to go first, to see your thoughts on that. Looking at Mary now? Okay.
All right. Thanks, Anne. Um, Again, I mean, I'm preaching not to the choir because you actually know this better than me. So, um, but something that as an advocate, I'm often trying to remind decision makers is kids aren't small adults. They're not just in littler packages. And because of that, time is of the essence. Their development is so time sensitive that if you miss a developmental screening or the anticipatory guidance at a well child visit, that can have such a significant ripple effect on that child's development. And again, I think the way our healthcare system is set up, as pediatricians, you are the front door to so much beyond your clinic walls, whether you like it or not, or whether you have the bandwidth to or not. But I mean, I can think even of myself when I have a concern, my daughter's pediatrician is the first place that I go to. And so if because coverage is interrupted or there's miscommunication that I don't think my child has coverage anymore, one missed visit for a child is going to have a more profound effect than, I'm guilty. I just was filling out a form being like, I have not done a primary care visit this past year, so it's going to have a much more devastating impact. And I think particularly for some of the disparities that we see in health outcomes in our state, those are just going to widen with any of these disruptions in care. So I'll leave it there. And Anne, if you have anything else to add, love to get your thoughts.
You know, I think I would think about, and maybe I'm moving ahead into sort of what do we do, um, is I think because kids are not the direct target of a lot of these cuts, I think a really valuable pediatrician voice is certainly to talk about the impacts on kids. I also think there's a really important voice about what a pediatrician could talk about in terms of how does the health of a parent help impact health of kids. I think if there's to the extent that we can talk about the ways in which untreated mental health, for example, in a parent has, health implications for kids. And that is not just, I mean, I think that is both because we know actually a healthy parent is better for kids, but it is also, I think, the best defense against some of those the protecting adults coverage will actually protect kids coverage. And so I think really developing sort of a framework where we're talking kind of holistically around the family and the importance of healthy parents on kids is, I think, just a place where I think a pediatrician voice could be really helpful.
Thank you for that. Since we've already started talking about it, I think I want to dive deeper into that pediatric voice. So opening this up to all three of our panelists, whichever one wants to go first. How can pediatric providers improve communication and collaboration with both SNAP and Medicaid agencies and thinking about what those conversations could look like? I know, and so who goes first?
Well, I will maybe make a quick plug here. Sorry. For a project that Mary Nell and I are collaborating on, Anne's involved with, that's really focused on administrative advocacy and improving relationships with our state agency. But I think there's ways that, pediatricians could do that on your own too. I will invite you to join our group. But also I think there's ways that you can just be communicating with HHS. I know sometimes I feel intimidated, like reaching out, but I've learned over my career that it sometimes is just that easy reaching out and asking for a meeting. Sometimes you don't always get it. But I really do think that you all are very trusted voices. And so, engaging both with, the state agency, but also your state legislators. Um, I don't know that I'm answering the question here. So Mary Nell, Ann, help me out.
Yeah, I mean, I think you all, you don't have to become policy experts and you don't need to know about the payment error rate or what have you, but you are on the front lines. And unfortunately, a lot of times families might not realize that they don't have coverage until they show up or try and schedule an appointment and they find that out. And so I think HHS is building the plane as they're flying it. They have just gotten huge changes dumped on them. And like we said, like things that are going into effect in 3 days, they don't even have any guidance on how to implement them. Incredibly complex, and they're doing their best. And they don't have the staff or the resources to do this. So even with best intentions, things are going to fall through the cracks. People are going to fall through the cracks. And so I think you all on the front lines can provide some of that. Yeah, I know this kid was still supposed to have coverage, but guess what? Something in your eligibility system kicked them off. And as a result, these are the consequences. And like Anne said, like being the messengers of this is what it meant that that child did not get in for this appointment. So I think kind of like Luke and Anne were saying, we're about to see what's going on with SNAP when SNAP goes away. As some of these Medicaid provisions get rolled out, as you see kids showing up with higher rates of food insecurity, you're going to be some of the first ones to actually see the impact of these. And so developing some communication pathways, whether that's even utilizing Seth and Christina or other partners in the community, the group that Luke mentioned, to get that feedback loop to HHS, they need that. And then hopefully they can make some course corrections. So I also don't think I answered the question.
Well, Mary Nell, I think that was a lot better than my answer, and it also gave me a spark. Because I think like sometimes like I'm a bit of a policy wonk. We get so into like, well, the policy says this, and that's not always how it works in the real world, like you said, Mary Nell. And there was an example today, the whole SNAP benefits question. There was a question of whether people were going to be able to use their benefits after October 31st. And USDA hadn't made it clear. They finally did last Friday. But I was talking to some folks on a call today, and they said, we were told today by people who called the number on the back of their EBT card and were told that they wouldn't be able to use their benefits after November 1st. Well, that call center is operated by a vendor that is not HHS, that contracts with HHS. And so I immediately reached out to HHS and I said, "Hey, I know all you have been very clear about this, but can you please make sure that this vendor is not providing misinformation?" And they were very appreciative because they weren't aware of that. And so I think like having that on the ground, like Marianelle was saying, like, hey, this person should be exempt. They're not, like flagging those cases. I think a lot of times people don't realize like you have more power than you may realize. Um, and your voice can make a difference.
And did you want to add anything to that? Fair enough. I feel like y'all gave a lovely groundwork here to talk about partnerships because you've brought up a couple different projects and various coalitions that can take part in this. So I want to really lay that out. Yes, we all have limited time in what we can take part in. So this is very much up to each individual person as to what they feel they have the capacity to do. But I really want to talk about what effective partnerships look like, especially between child health, food security, public health groups, and thinking about where's your recommended place for a pediatric voice to get the plug in. So if I could just have the master list, that would be great, and I can send it out to everyone. But opening up to the floor to your thoughts on that.
I can start. Well, I mean, one, I think advocates are also building this plane as we're flying it. So I'm not sure we have full information about that because, and this is going to play out on all these different timelines, right? SNAP's here, 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 Medicaid's here, here, here. And so I think there's a little bit of stay tuned and keep in touch with Christina because I think advocates are going to want to find ways to get to you, to get you to you all. And so I think Mary Nell made the point, and I think this is absolutely right, is that you do not have to, that the voice that you bring is not the, I must know the detailed, implementation of X policy on Medicaid or SNAP. It is the impacts. It is the impacts of cuts. It is the impacts. And I'm gonna do my pitch and speaking of getting out of comfort levels, but I have to do it. So we do some administrative advocacy at Common Good Iowa. We probably do more legislative work, and we do a lot of work on the budget, and we do a lot of work on taxes, and a lot of advocates who care very much about the services that are paid for out of the state general fund do not have opinions on taxes for all sorts of very good reasons. Like I get them, I've heard them. We can't have services without revenue. We are starting to see the impacts of like 4, 7, 8 different in personal income tax, corporate income tax, inheritance tax cuts since 2018 that are gonna, open up what is essentially a structural deficit in our budget. And so you do not have to be a tax advocate. You do not need to understand the subtleties of the flat tax. If you want to, I'm happy to talk. Um, but I encourage you as you think about places where either just on your own dime, as you think about candidates, as you think about calls you might personally make, as well as wearing your pediatrician as part of the American Academy of Pediatrics hat, just to think about where you might have a little bit of room in your hearts for discussions of revenue, which are going to be really important because Medicaid is conservatively 20%. Medicaid and Hawkeye are conservatively 20% of the budget. That's just the line item in the budget that goes to Medicaid and SNAP. There's a lot of other parts of the HHS that actually touch Medicaid and Hawkeye, even if they're not that line item. We can't sustain incredible revenue hits over year after year and leave Medicaid untouched. It's just too big of a part of the budget. And if we leave Medicaid untouched, it means we're cutting K-12 probably. So I don't think I answered your question at all, but I just had to get it in there.
Well, I will make a plug if you are interested in SNAP advocacy for the Iowa Hunger Coalition. I do serve as a board chair of the Hunger Coalition. We send out an email newsletter periodically with updates. And we also have a monthly meetup call on the third Wednesdays of the month at 10 a.m. So if you would like to get more involved in SNAP advocacy, feel free to look more into the Hunger Coalition.
Mary Nell, is there anything you'd like to add? Okay. Um, Looking at my last curated question before we open it up to the floor, if every person in this virtual room, because we're not all sitting down together, um, and they took one actionable step tomorrow to either address children's coverage of Medicaid, which we know is coming in the future, so trying to like grease those wheels to maybe put a stop to things, or access to SNAP, which we are seeing in real time. What would you recommend? And Mary Nell, since you didn't speak for the last question, I'm going to look to you first.
Okay. So I don't know. Hopefully, this isn't too much of a cop out because I'm like the Medicaid person, and I would say the messages don't cut Medicaid. But honestly, I feel like I need to be a quieter voice on Medicaid and a louder voice on SNAP. As Luke outlined, there is a lot of immediate threats to SNAP right now. So I think you all, as we've talked about, are trusted messengers, and I think you can play a really critical role in educating lawmakers about what Medicaid actually is, as basic as that sounds. Um, a lot of legislators have a perception of what Medicaid is, and they do not really understand that it's covering half of kids in the state, that it is one of the largest, it's the largest payer of behavioral health services. It's a fundamental piece of our healthcare delivery system. As goes Medicaid, goes our healthcare delivery system. So doesn't matter if you're on it, you're going to be impacted by it. So I think, again, not in the weeds policy, but you can do a great job telling the story of how Medicaid provides access to necessary healthcare to help our kids and families be and become healthy. But I do think, and this is, to piggyback of what Anne was saying, I was like, note to self, need to be in revenue conversations because I am guilty of that. I think as advocates, we need to zoom out and say a lot is under threat. We need to have that big picture of what does our budget look like, where is our revenue, and right now a lot of the Medicaid provisions are going into effect in a couple of years. SNAP is under the gun right. Well, I don't like that line. SNAP is under threat right now. So educate about what Medicaid is, but let's be partners in talking about revenue, and let's be partners in talking about protecting SNAP.
I would just say in the immediate next few days, if you want to reach out to your local food pantry and see how you can help, I would encourage you to do so. If you're able to donate food or funds, if you're able to volunteer your time, I know food banks and food pantries are going to get hit like we've never seen before next week, and the following week, and who knows when this will get resolved. Um, but I also would say, aside from the shutdown and with some of these big changes coming at the state legislature, if you haven't already, I would really encourage you to figure out who your state representative and senator are and reach out and introduce yourself and actually ask for a meeting. That would be my ask for you, is reach out to your representative and senator and ask to meet with them. I cannot think of a more trusted voice on child nutrition than pediatricians. Maybe brain scientists. I don't know. And maybe some of you are brain scientists. So sorry, I don't mean to, to label you. But I mean, I think you have some really valuable perspectives to share. I have definitely gone through periods of political apathy in my life where I feel like nothing I say is going to make any difference. Still feel that way sometimes, but I am here to tell you, at least with your state legislators, and I'm sure some members of Congress as well, they look to you as a trusted voice. Maybe not 100% of them in our state legislature, but a whole lot of them do. And so talking about the impact of child nutrition and brain development and physical development, we know that, a kid's access to healthy food early in life can make a difference for the rest of their life. And so that's what I would encourage you to do. Reach out, see if they would be willing to meet with you. You'd be surprised. A lot of them will probably would be. Or try to catch them at like a, coffee hours or town hall or something like that. Every single state legislator I have spoken to has not been aware of all these massive changes to SNAP. So we're doing a lot of educating. And I'm happy to share, like the Hunger Coalition has a write-up on all those changes to SNAP. If you want to just educate yourself a little more, but like Marinelle and Ann said, like you don't have to get into all the policy specifics, just talk about the impact.
Thank you. And is there anything you want to share as a last minute effort? Okay. I feel all right, fantastic. Well, then I'm going to open up the floor for all the burning questions that our members have had and have asked me in various conversations. What are your questions? And yes, Dr. Kimball, I will share I've been taking notes for the resources, so I'll share them in a follow-up email.
I'll chime in. Sorry. So Amy Kimball. So first of all, thank you all. It's always great to kind of connect with people that are like-minded and have kind of some of the same goals, and also to, I think, just for us all to kind of regroup and identify our resources and covering these directions for children. I think, a lot of us are already running into issues, and I think one of the struggles that I know we're seeing, I'm in Winterset, so I'm covering very rural areas, and I have my children in Madison County, but even further south. Access to even help these families find a person to talk to. I have so many families that are already like they were in enrollment, or they thought they were enrolled, either for Hawkeye or for from Medicaid, and they don't have that information back, and they cannot get to a human being to, are those things that, and I'm trying to work with our social workers. So are those direct contact HHS? I feel like I get stuck on the phone forever when I try to do that. So I think those are things that if you have ideas of how we can direct these families, I feel like that's a moving target. I know our social workers will find a resource and then they call that resource again and they're not available. And it's just, we know that there's ways to help these families and to not have them give up. But if they keep coming back and then they can't get to anybody, they start to give up and they kind of quit coming. And I think that is, if there's a way that we can, and not even necessarily tonight, but kind of help funnel that information, or if you have ideas of where we can make sure that we ourselves have that information, but that we can channel that out to other pediatricians in the state, to our family practice counterparts that are covering even more of those rural areas, because I truly am having families just coming up and throwing up their hands. The food pantries that they were going to are closed, and and especially the immigrant population, they're just scared to have to go anywhere because they're scared they're going to get taken away. And it's just, I've never felt like I was in a time where I just didn't even, I used to always be able to say, okay, let's sit down, we can call this person and we can get things going for you. And so, and I know you may not have the magic wands for that, but I think those are things that that we can help our patients, but I think those are things that can help people within the state as a way for people to advocate on top of contacting our legislators, because they hear from me very frequently, by the way. So, but I think, that would be an area that if you have any ghost whispering information on that, that would be awesome.
I don't have a good answer to the right now question, and I think it's a real question. And I think that you mentioned immigrant communities right now that I think feel very adrift. I think Mary Nell and I have had the very earliest talk around what are the policy levers to deal with that, or is it so I don't know. I always think like water runs downhill, right? So this is the federal government made these big cuts. A lot of them are getting pushed to the state level to implement, but the challenges are going to show up in communities. I was doing some presentations about this last week, and I was sitting in Cedar Rapids with a couple of churches, and like people are like, they were just and I walked through in gory detail the work reporting requirement details for parents, because again, there are many parents who are covered by expansion, even if they don't, they're not getting their Medicaid because they're a parent, but they are a parent. And it's ugly. It's, well, you 80 hours of this or half-time school or 80 hours of this or a combination, except for it's really minimum wage times, 80 hours a week. And then there's the 10 exemptions. And they're just like, how are people going to do this? And so I think it is both the advocacy at the state level and at the federal level, both over the next few years. But I think absolutely there need to be community conversations. So these churches are like, what can we do? Oh, people are going to have to volunteer. How do we help? Can we do volunteer? Is that something we can do? Could we help people where people could get volunteer hours and they could help? I am a strong believer in resourcing existing organizations that already have ties to the community, that have cultural knowledge, language, culture. You know what I mean? Like we should not be reinventing the wheel here. Let's reach out to churches that are already embedded in communities, community groups. So I don't know because I think the resources are incredibly thin, although I look to Luke or Mary Nell, but I do think that there are going to have to be community conversations about coming together around helping folks.
I 100% agree, Anne, and I think some communities are in a much better position than others when it comes to this. I know in the Des Moines area, like DMARC, we operate a food pantry network. We're all talking with each other. There are some counties like up in Spencer, the Clay County Hunger Coalition there. That's, I think, the library and the hospital kind of working together and bringing community partners. Sometimes maybe a hospital can serve that role, or a public health agency, or a library, or another community center. But we've been seeing a trend of this happening in Iowa, of more communities realizing like we have to get better at talking to one another and letting our shared clients know about each other's services and that sort of thing. So um I actually don't know what that looks like down in Winterset. I'm not sure if Madison County I don't think has a hunger coalition to my knowledge, but there might be, whether it's a United Way or some sort of convener. I think, and if that's not happening, hopefully someone will step up. But I think those community kind of coalitions, again, whether it's like city, county government, public health, whoever is hosting, like someone needs to be convening and bringing people together to talk about this. And we've also been seeing a trend, almost like a get bigger, get out trend with food pantries, which I can't believe I'm saying, where some of the smaller, less resourced pantries are closing up shop because they literally cannot keep up. And then the larger food pantries are hosting capital campaigns to, have a huge new food pantry to meet the need, which, like, I'm glad people can meet the need, but I don't think our response should be more food pantries hosting capital campaigns, if you ask me, of addressing hunger. Um, and so I think we'll continue to see that dynamic as nonprofits are being asked to do more with less.
Um, I'm gonna put in the chat a link to Hawkeye outreach coordinators. They're regionally based. So if you scroll down to the second page, you should see a map to see what counties they serve. And a lot of them are housed within health departments. It looks like the link I sent you doesn't have like the Hawkeye outreach coordinator specific name, but if you called the Webster County Health Department and asked for the Hawkeye outreach coordinator, I think they would be a good resource. They are deeply embedded in the communities, often coordinate back to school outreach. Their purpose, as their name implies, is to enroll folks in Hawkeye, but I think would be an excellent resource because a lot of times they'll help a family complete an application and say, hey, you're actually eligible for Medicaid. So I think in the very near future, I would start there. But yes, long term, we have to figure out some sort of community level response. So thank you for raising that, Amy, and I think let's keep as advocates working on that.
And we did have a question in the chat also from, well, our other Amy, we have Dr. Amy Shiver and Dr. Amy Kimball also trips me up as well. Are
Yes.
there ways we as pediatricians, and I'm not a pediatrician, I don't know if you knew that, but I'm not. But how can you write letters for waivers for work hours?
I don't think so, because I think it would need to come from the actual member's healthcare provider. So no, I don't think you can directly. The state hasn't put out guidance for like what medically frail is going to look like or what those provider exemptions are going to look like. I think potentially you could help build the case for someone who is a caretaker. Is it 14? I think is the age, kids for 14 and older. So I think pediatrician's role would be more on a different type of exemption. But no, I don't think, unless it was like an 18 or 19-year-old, I guess, you would be able to provide a waiver for work requirements for those young adults that are in your care, but it has to be the direct provider. And you're on mute, Amy.
I've already been asked by parents because they say I'm the only caretaker for this child and I have to stay home with this young child. And so you as the pediatrician should be able to write me a waiver because I can't work because I need to take care of my child. And so I was like, well, I don't really know the rules. So it's hard for us to answer those types of questions.
Yeah. And I mean, I'm glad it's on people's radar. Like this won't be going into effect until like for another over a year about for Medicaid at least. And so hopefully we'll have much more clear guidance on what that can look like. But I think you've identified what should be built into the system as a pediatrician, you should be able to document the role of caregivers and get some exemptions in that line.
So when we're talking about giving that feedback, because our members are frontline workers and seeing these families kind of deal with these issues as they happen. When you're talking about giving that feedback, who are you directly stating we should give that feedback to? Like, do we go directly to like our new Medicaid director? Do we have to go through, yeah, who would be a point of contact, which is very difficult because HHS has vocalized a no wrong door policy, but I have frequently found that to be not necessarily wrong. It's just confusing as to, they're still working things out. So yeah, if you have a wonderful answer to that, I would be happy to share that.
I think whatever relationship you got in the short term is a relationship that you should work if you have a tie to anybody at HHS or, a legislator. But I do think actually when we start thinking about that flying the coalition plane that you referenced earlier, I think that's a place where like a coalition could help, gather some of those stories and package them in ways that we got them to lots of people who should hear those stories. So I think it's actually a good challenge for us advocates to be thinking about how we can, in addition to you using your relationships, how we can help facilitate some of that.
I guess I would and I'm volunteering you, Christina and Seth, but I would say just to make things simpler for you all, if you just want to send things to Christina in the near future, we're in frequent contact with Christina and Seth. And so we can then figure out, because you don't need to be trying to figure out the org chart of HHS. So maybe just for right now, until we build something better, I'm going to give Christina another thing to do on her list.
That happens quite a lot, so it's okay. Sorry, Luke, didn't mean to interrupt.
I was just going to add, one thing I've been trying to plant the seed with people. When I talk with members of Congress, a lot of the time at the end of the meeting, they're like, oh, and a reminder, we do constituent services. So if anyone has issues getting Social Security benefits, send them our way. All these folks who voted for these changes to SNAP and Medicaid, I would encourage you to have that person, if you believe that they should be exempt or had an issue, contact the local office. If they have a Des Moines office and you're near Des Moines, have them contact that Des Moines office. If it's a Cedar Rapids office, have them contact that office. Ask to talk to someone in constituent, services, and go and bring this to them, and say what gives. Like, I thought my kid was supposed to be exempt, or I thought, um I don't know that will get results, but it's worth a shot.
Thank you.
I think anything that's a feedback loop at this point, and I think especially with members of Congress who are perhaps less engaged, I think lawmakers are much more accessible. I think anytime you can do a feedback loop, that's fantastic.
Thank you for that. Does anyone else have any questions?
I'm negotiating trunk or treat candy with she's like, can I have this one and this one? Yeah.
Okay, going once, going twice. I mean, we have your contact information. I will be sure to shoot off many questions as they come, especially as we enter into this new legislative session, which is round 2. But I want to thank all 3 of our panelists. Apologies. Okay, Bola. Bola had a question about, I think that's the Rural Health Transformation Fund. I don't know if anyone here has the expertise to talk about, how we advocate for how that funding is utilized. But I will drop that at your feet if you have feedback for that.
Okay, I'll try and be quick. So when HR1, they were struggling to pass it, something that slowed it down was people pointing out the devastating impact that HR1 would have on our rural hospitals. So the compromise was to create a rural health innovation trust fund, slush fund is a more accurate term, to try and shore up the rural hospitals. Spoiler alert, only 15% of these funds can actually go to rural hospitals. So half of the funds are going to be divided evenly across all the states, whether you're rural or urban. And there was a very quick, I think actually November 5th is when applications are due for that, and then funds will be dispersed by the end of December. So all states will be getting, I don't know, like 100, 500 million, something like that over the next 5 years. Sorry, my numbers are a little bit fuzzy. But pretty much most states will be getting a chunk of money. And then the other half is completely at the secretary's discretion, aka, oh, you voted for this, I will give Alaska some money. Sorry, obviously the filter has come off at this point of the evening. But Iowa was one of, I think, only 2 states that did not request public input in their application process. So this was something where I know Iowa Primary Care Association had one representative at the table. Iowa Hospital Association also had someone at the table, but this was done very in-house. HHS Director Garcia was leading it, and now she's gone. So yeah, we didn't have much input in the application process, but I do think you raise an excellent point that there will be some sort of notice of what the state plans to do with this. And I'm assuming they had to be relatively vague since they had like 2 seconds to put this application together. So tremendous opportunity to say, hey, this is actually how funds should be dispersed. So yes, thank you for raising it. And I apologize for all of my snark and not jaded. Anyway, I'm going to be quiet now.
And Amy, I see your question. The funds aren't long-term or sustained, correct? Correct.
But we do have a SNAP waiver, which gets us extra points on the application because we're restricting what foods people can get. Which I definitely was not put in there to try and get more states to do that.
Mary Nelle, you're much less snark than I can be, so you did well.
Yeah, I think that was an appropriate amount of sass. So thank you for providing that to the group. Dr. Shriver asked, what can we do to push back? I assume you're referencing the funds. Go ahead. Sorry.
I mean, everyone I've talked to about this, like I was just talking to Cheryl Jones about this at the University of Iowa, and like she's like, I don't know what's going on, and I don't know what's going on either, and the AAP doesn't know what's going on, and IMS doesn't know what's going on, and Common Good doesn't know what's going on, and like this like lack of transparency deserves like some sort of pushback about it. And so is there any plan to do that? I feel like we sent, as the AAP, we sent a letter that was, drafted based on other states' letters to their planning groups saying, don't forget about kids. You're going to forget about kids. These bills have a huge effect on kids. And now you're going to just write some stuff and forget all about the kids. So don't do that. And, we really hoped for a seat at the table. And of course, we didn't get one, and neither did you or you or you. I think that's going to have some repercussions. I just wonder if anyone has, do we have any ways to communicate our upset feelings about this?
I mean, this is just my personal opinion, take it or leave it, and Anne and Luke jump in as well. But yes, I think we need to raise the lack of transparency. We can call out that Iowa is one of only, like I said, 2 states that didn't do this. I don't think that is your card to play as a pediatrician. We keep talking about you being a trusted messenger. I think that's a bigger conversation about the lack of transparency overall, as your boards and commissions get condensed and eliminated, there's overall lack of transparency. Everything's being taken in-house. That's a conversation, and I think it needs to happen, and I think we should talk through who the messengers are, and we want to have broad messengers, so it's not just one bad guy saying that. But I think if you want a seat at the table, I think it doesn't do you any good right now to say, hey, we didn't get a seat at the table, we're mad, this isn't transparent. I think you say this is how the funds should be spent, and as coalition partners, we need to come together and say, how do we have this bigger conversation about lack of transparency? But I would recommend you keep I'm a trusted messenger as a pediatrician. I know what the hell I'm talking about. And I think this is how the funds should be spent now that you have them.
We are in strange times, and I tend to be a loudmouth myself and am not afraid to tell people how it is. And I'm needing to do some very strange pivots right now because of the existential threat to programs like SNAP. Um, so I would echo what Mary Nell said. Doesn't mean that you can't, hey, reach out to a reporter who's been covering some of these issues and be like, do you know what's going on with the Rural Health Fund? Do you know, like, maybe there's some questions to be asked there, but maybe it's not the time to be drawing heat toward your particular organization. You may have more success in the future having that seat at the table. I'm not saying like don't say anything, like, because I don't think that gets people anywhere either. Like
No.
having a seat at the table if you're not taken serious on your, position, and then that's just a token space on something to fill a role, I feel like. So I'm rambling. I'm going to let Anne talk because I know she's got some thoughts, I can tell.
Oh, because this issue makes me kind of go like this. Um, I think it is a cultural issue in HHS, frankly. I think we have dealt with it in other human serving parts of that department. Um, and I am representing a nonprofit, nonpartisan organization, so take this with vaguely as it will be said. Perhaps a different administration would make different choices around openness at the Department of Health and Human Services. I have no opinion on who that other person would be. I do not. Institutionally wearing my hat. Um, I think it's being realistic. I think it's being realistic about what we can do with the current people in certain roles. And some of this is probably going to take different people in those roles. And I suppose there's different ways to get there. But again, as you think around your, lives over the next year or so, I would suspect that this would be part of the equation when you think about who you vote for.
I greatly
So there, that was
appreciate
my like, that was my snarkiness.
No, that's perfect because November 4th is right around the corner. I'm gonna go ahead. We're over time, so I do apologize for that, and I want to be wary of everyone's time.